everyone. So thanks for joining this session. My name is Ian Wharton. I'm one of the founders of a company called Aid Health. So I'd like to share with you some of the work we've been doing over the past 2 years, but also some of the learnings, some of the findings, specifically as they relate to the management of long-term conditions and also specifically comorbidity. In particular, we'd like to talk about bridging essentially the insight and the intervention between the individual and also the patient population. And of course, we'll talk a little bit about what we think that means for the future. So Aid Health is a digital platform we launched early this year in the NHS. And our view really is to help clinicians and patients in unison better manage, better understand long-term conditions. Now, we do that in 3 ways. We help with the medicine optimizations bit. We help with structured monitoring. So, for example, capturing blood pressure readings for a hypertensive patient and reducing some of the clinical admin that goes along with that. But then also structured education to help people improve their levels of health literacy contextually or over time. And the goal, of course, is 2 things. It's to help improve an individual's ability to self-care alongside improving and supporting clinical assessment when the 2 parties do come together for consultations. Now, we've got a particular interest in comorbidity. We launched with asthma and type 2 diabetes. We're adding hypertension very shortly. Really, we're working as hard as we can to cater to the top 10 long-term conditions in one single platform. We fundamentally believe that both clinicians and patients do not have the cognitive bandwidth to manage multiple apps for multiple different conditions. Really, it has to be all done in one holistic way. The reason we're doing this, first and foremost, is just to meet the undeniable rising human and economic cost of long-term conditions and comorbidity. So for the people in this room, we don't need to necessarily dwell on the figures. You will be very well aware of the impact of long-term conditions. But for example, in less than a decade, we've seen people admitted to hospital with 5+ conditions was 1 in 10. It's now 1 in 3. And that was kind of roughly a decade or so later. And the broader impact of healthcare utilization, we see higher mortality with people with comorbidity. We see greater need for both inpatient and ambulatory care. And we see reduced functional status. That's when care can get incredibly expensive. So we certainly don't profess to have all the answers, but we thought we'd share with you our perspective that might help organizations and your practices better manage long-term conditions. I should probably also say where this perspective comes from. So myself and Brian Snyder were the co-founders of Aid. We are not medical people. We're product people, essentially. We've been spending the past 20 years of our lives building digital products and services with some of the biggest brands in the world, people like Nike Digital Sport, all the way through to digital services for Formula One. However, the reason we started is from lived experience. We have both had our challenges with long-term conditions, and that was our instigation for starting Aid Health. We've got deep research experience with Professor Nick Barber. He's Emeritus Professor of UCL, former Vice President of the Royal Pharmaceutical Society. And we've got really deep, substantial expertise with population health, person-centered care, and also shared decision-making with Stephen Leitner. So we'll share 4 things, and the first of which is the challenge of polypharmacy and how we might help people manage their medicines. Of course, polypharmacy very common in comorbidity. So the burden of medicine falls heavily on the individual. So there's a couple of things we can do here. Technology has gone some of the way to help people manage these things day to day, but you could argue that it's leaned too heavily towards providing base utility and not really facilitating people in the best way. So for example, if you take a medicine reminder app, typically what it will ask is to designate the first medicine. It will ask you to state the first dose. It will ask you to decide what time that should be taken. And then you've got to repeat that for dose 2 and dose 3 and add all these times. And really, if you've got any kind of multi-conditions, you see that over time this builds up to a pattern of roughly 40 different interactions you might have to do in the very first instance of using a new service. On average, we see people between 4 and 5 medicines with comorbidity. So there's a lot more we need to do. We need to reduce friction. We need to provide the path of least effort. And the behavioral science on this is pretty clear on this topic. There was a great piece of research done by psychologists at Harvard University. They worked with the Department of Education, and they grouped 3 different groups of parents, and they offered them a service to help their kids study. And the first group were given a text message saying you can sign up by filling in a form on a website. The second group said you just have to reply saying start. And the third group was automatically enrolled, but they had to text stop to opt out. Now, conventional wisdom would say these results would be somewhat obvious. There was a wild variation in rates of adoption based on perceived level of effort, from 1% to 97%. But the psychologists also surveyed 130 education experts and asked them to guess what they thought the implication of this would be. And even though they saw the trend, they were heroically wrong in what the impact was. So there's a learning here that the psychologists posed, which is we spend a lot of our attention trying to motivate someone, a patient, to take a certain behavior about their health. Perhaps we're underestimating the value of just providing the path of least effort, in particular when it comes to adherence to medicines. So if we look at AID, this is something we've been exploring. On the first day of a patient using AID Health during our onboarding, we provide a short interaction called Set My Routine. And AID for the patient is predominantly experienced through natural language, so through short daily conversations. The first thing we do is ask them for their wake time. We then ask them what their sleep time might be, and we ask them to tell us the times of their 3 main meals during the day. This takes on average about 35 seconds for a patient to complete. From there, we can stratify their day. And AID, in the background, looks at their day. It automatically assigns all of their medicines, when they should be taken throughout the day, any agreed monitoring. We even go as far as telling them to the minute when the next event is. And we present the whole thing in this timeline of their day. So it's this balance of providing a sense of agency for patients, but also minimizing burden, providing the path of least effort. It's this clarity of presentation that we're afforded with emerging technology. So the second thing is about medicine beliefs. We have this great gift with natural language, which is we can find out really highly personal stuff about people's relationship with their medicines, and we can do lots of interesting things off the back of it. So this is, broadly speaking, what a medicine reminder looks like in AID. We greet the person by their name, we tell them the action, in this case, to take their amlodipine once a day. This is a hypertensive patient. And then we provide quick links for them to respond to that. They can say, I've taken it, or maybe they can't in that moment. So if the patient says, I can't right now, the first thing we do is just say, do you want to be reminded in 10 minutes or 30 minutes? Because they might just be driving the kids to school. But actually, we can go much deeper and find out other ways of supporting them. We can ask them why that might be. Everything from, I just don't feel like taking it, to I've run out. And maybe we can facilitate easier prescription fulfillment. But if a patient does say, I'm worried about side effects, this is an expectation. There is a context set, because it's conversation, where we can dive a little bit deeper and find out some more information. So, for example, we can speak with empathy to Alberta. We can say, sorry to hear that. Let us know what's happening when you take this medicine. In this case, the patient says, I get a headache after taking it. And then we offer a subjective response of severity of that condition from the perspective of the patient. So if they say mild, we might say, well, you know what, this is actually quite common with calcium channel blockers. Here's a piece of content, but let's keep an eye on it for 7 days. If they say severe, there's probably a higher chance of them becoming non-adherent, and we can take a different action. Particularly important, potentially, for hypertensive patients where they might have been asymptomatic for a long period of their life. Suddenly they're on medicine that might make them feel quite unwell. It's better to discover these things quickly rather than potentially 6-7 months later at their checkup with their GP or long-term condition nurse. Alongside that, we actually conduct things we call check-ins, and we do a check-in on patient confidence, on mental well-being, but also on medicines. And these things are scheduled every week, every month, every 6 months. It's very tailorable. But we answer 4 questions about medicines, and we can certainly take intervention in that moment for the individual. Actually, we've learned really interesting things at a population level. So during our pilot in NHS England, we had 41% of patients say, I stopped taking my medicine when I feel well, when I feel like my condition is under control. Now, we obviously pass that information back to the practice or to the PCN, and they can choose to take an intervention. Maybe they want to create a patient participation group for that subset of their patient pop to do something about it. There's also some evidence here that potentially patients are much more willing to disclose honest information to intelligent systems as opposed to human beings face to face. There was some great evidence to support this. Researchers at the University of Southern California created essentially a consultation with an entirely virtual clinician, a 3D virtual clinician. The subjects knew that they were participating with that. What they found is that humans were far more willing to talk openly about their challenges with this virtual assistant, to the extent where they studied facial expressions and found people are highly likely to show more intense signs of sadness, which you could argue is one of the more vulnerable expressions you might have. So our view very much is that supplementing clinicians with these types of tools, rather than using them to replace clinicians, which we just absolutely don't believe is the right scenario, might help get to better outcomes more quickly. So the third thing is a quick note on written care plans. So many of you might remember not too long ago the NHS had an important declaration to try and get every long-term condition patient a written care plan that they could refer to know what to do when things start to go wrong. Even by the NHS's own numbers, 5.5% of people have a written care plan today if you have a long-term condition. So if we consider this to be a goal that's worthy of our attention, there's clearly a little bit of work to do. We should ask, why is this a problem necessarily? And really it's a problem of retention of information. So the Helmholtz Institute concluded in their research that as much as 80% of the information given to people in a consultation is forgotten almost instantaneously. So there is a base level of information we can provide here to help people self-manage to understand their conditions. And again, this is something that we've explored in AID. So on day one, we provide a written health plan for the patient. We refer to it as a health plan. 100% of people who use AID Health have a written health plan. And it gives them the medicines they're on, the dosages, but also what that medicine does, so why they've been prescribed, and maybe some insight into how to best take it. So if you're taking an inhaler, it's a slow, deep breath in so the medicine doesn't hit the back of your throat and become therapeutically ineffective. Now, we've got a long way to go until we really figure this out, but already we're seeing interesting patterns. This is a close-up of the homepage of the AID patient app. And you might see here there's a list of suggested quick actions. These are essentially shortcuts to triggering a conversation with AID, and one of them is to review the health plan. And what we found in our pilot that over 1/3 of patients ask for this health plan at least once a month, every single month. In fact, a lot of them ask several times throughout the month. So there is a need here. And often it's small, simple things, low-hanging fruit that we can support patients with to improve their ability to self-care. And then finally, just a note about reaching those who are most affected. Long-term conditions, no surprise to anyone in this room, skews towards the aging population. It skews towards slightly more deprived areas of the country. And there remains today, even today, this certain discourse that technology or emerging technology can't service this group of people because they don't have access to the technology. Now, if we'd have looked at the data from 2017, that would paint that picture somewhat. If we look at the difference in socioeconomic group of kind of smartphone adoption rates. But if you fast forward 5 years, it's a wildly different picture. There's only a 9 percentage points difference between the A, B, and D socioeconomic groups. So smartphone is a baseline requirement for good emerging technology, and what we're finding is the vast majority of people have access to that technology. And then secondly, of course, is the aging population. So the vast majority of digital health, it's probably fair to say, stops at age 65. In fact, a lot of medical research stops at age 65, and we think that to be needlessly exclusionary. You just have to design the interactions in the right way. So in fact, in our pilot, our oldest user, in fact, our most improved, most engaged user was 71. And what we saw was over the course of 3.5 months, that person's adherence to their medicine started in the classic 45-50% range to over the course of 3.5 months, consistent weekly streaks of 100% self-reported adherence. So there is an argument to say, yes, sure, these groups of people need technology, but actually there's a desire from these people to have new experiences to help them manage their health. So long-term conditions, comorbidity, undoubtedly one of the greatest challenges facing health systems in the developed world. It requires interactions that speak very privately to the individual and help interventions in that moment, but also at scale at population level. And we just need the right tools in order to facilitate those interactions. Our view very much is that modern design, modern use of emerging technology, the correct use of emerging technology is going to make that possible in the next 5 years. But we have to do that alongside the more macro picture of long-term condition, which is help accelerate this move from disease-specific care to whole-person care. So we're working with a range of organizations in the NHS and very specific use cases for single conditions to kind of broad multi-condition use cases. Love to hear about challenges that some of you may have in your PCN or your ICS and see if we can further support your population. So thanks very much for your time.
you.